So we're in Unit 2 now. In Unit 2, we're going to cover the family of organisms known as the Streptococcaceae. We're also going to talk about an organism called Neisseria. We're going to go through respiratory and throat cultures, sexually transmitted infections, and direct smears. In this very first lecture for Unit 2, we're going to talk about Streptococcus and Enterococcus. And just like for Unit 1 with the Staphylococcaceae, there is a strep flowchart that could be very handy for you. So if you compare this to the flowchart that we used in Unit 1, we're on the other side of that now. So remember, we used the catalase test to determine or to differentiate between staph and strep. So this flowchart is picking up on the other side of that flowchart that you saw in Unit 1. So again, we're dealing with gram-positive cocci. All of the streps are gram-positive cocci, and then the next test that we do is the catalase. So remember, the staphs and the micrococci are the organisms that would be catalase positive. We've already been through those, so we're on the other side now with the streptococci, which are catalase negative. And then just like with the flowchart in Unit 1, you kind of go from there. So the next thing that you look at for once you've determined that you're working with a strep species, hemolysis pattern is very important in determining identification and the testing that should be done on the organism that you're trying to identify. So once you've determined that you've got a strep species, the next thing that you're going to look at is the hemolysis pattern. And based on that, whether the organism is beta hemolytic, alpha hemolytic, or or gamma hemolytic, that determines the testing that you do from that point on to get your identification. Okay, so getting into some of the general characteristics, and again, this is overall just the for the strep family altogether. So we're talking about organisms that they're going to be a little bit smaller than the staph species. So the colonies are small, they're convex, they can be gray to transparent white, and you can see all three forms of hemolysis within the strep species. So again, the gram stain, we're dealing with gram-positive cocci again. The streps can be in chains or in pairs. So if that's what you're seeing on the gram stain, you're seeing gram-positive cocci in chains or pairs. That can be a very good indication that you're dealing with a strep species versus a staph. They can be spherical or elongated. When it says elongated, it means kind of like a football shape. And because of the very fragile cell walls that strep species have, they can turn, their gram stain can appear gram negative as the colony ages. So if you were to do a gram stain from the colony or the growth on the plate after several days, after it's been growing for several days, an organism that should be gram positive might actually appear as gram negative. So some of the lab tests that we would do to help us identify strep species, again, all of the strep species are catalase negative. Their hemolytic patterns are very important, and again, that would determine the next steps to take in testing to help us determine the species. Some growth requirements, so streps are aerotolerant, facultatively anaerobic organisms. So again, that means that they do not require oxygen for growth, but they will grow better in the presence of oxygen. Some species of strep also like an environment with increased CO2. Those organisms are referred to as capnophilic. Normal habitat for streps, so they are normal flora in the throat, nose, nasopharynx, lower GI tract, and vagina, except for group A strep. That is one of the strep species that will never be considered normal flora. Okay, Talking about the cell wall structure, so they have a very thick peptidoglycan layer with teichoic acid crosslinks, and that's because it's a gram-positive organism. If you remember back to Unit 1, the gram stain, the entire purpose of it is to help us classify organisms based on their cell wall characteristics, and those gram-positive organisms have cell walls that are made up of a peptidoglycan layer with teichoic acid crosslinks. They also have what's called a C carbohydrate layer, which is a polysaccharide or a type of carbohydrate present in most of the strep species except for strep viridans group of streps, which we'll talk about shortly. And this is mostly used for classification of the beta hemolytic streps by serotyping. And then a capsule can be present in colonies of strep pneumoniae and group B strep and in young cultures of most strep species. So the classification scheme, so these are commonly used approaches for the classification of these gram-positive catalase-negative organisms, which again, that makes up the family of Streptococcaceae. So the Lancefield classification, and you can see there are three different or four, I think, different classification schemes that we'll talk about. Lancefield classification, hemolytic patterns, physiological characteristics, and biochemical identification. So that first classification scheme that we're going to talk about is called Lancefield classification. So this is based on that C carbohydrate that's in the cell wall. It's done with serological testing, and it's only done on the beta hemolytic strep. So that would be group A, B, C, D, and then there's a few others beyond that. There have been discrepancies found in this system since DNA testing has become more common, so it may not be used quite as often now. Then we can also classify streps based on their hemolytic pattern. So this is used for an initial classification of the Streptococci. It can be very helpful, but some species can show variable hemolytic patterns, so you might have to do some additional testing to kind of narrow down and get your identification. So again, remember, your alpha hemolytic organisms are those that only partially hemolyze the red cells in the media, so they're going to leave that kind of brown to greenish coloration around the colony on the media. Beta hemolytic organisms perform complete lysis of the red cells in the agar, and that's going to leave that clearing or kind of a halo under and around the colonies. And generally speaking, the strep species will cause a like a smaller zone of beta hemolysis than the staph do. And then non-hemolytic, or also referred to as gamma, there's no hemolysis. So another way that we can classify the streps is by physiological characteristics, which divides the strep species into 4 groups. So the pyogenic streptococci are those that cause infections that produce pus. So these are mainly going to be the beta hemolytic streps and constitute most of that Lancefield group. Lactococci are non-hemolytic with Lancefield group N antigen. So a lot of times these are going to be found in dairy products. Enterococci, these species are found as part of normal flora in the intestines of humans. Most of these strains lack the C antigen, so they're not going to be part of that Lancefield classification scheme. And then the viridans streps can be alpha or non-hemolytic. They're generally normal flora of the upper respiratory tract, female genital tract, and the GI tract. A lot of times the strep species that fall into this group are going to be opportunistic pathogens. And then the last method that we can use for classifying streps is through biochemical identification. So these biochemical tests that we perform are selected based on the hemolytic pattern of the organism. Some of those biochemical tests that we perform on streps include the bacitracin susceptibility test, CAMP test, hippurate hydrolysis, PYR, LAP, VP, beta-D glucuronidase, bioesculin and salt tolerance, optogen susceptibility, and bile solubility. And if you go back to that flow chart, you should see I think probably all of those listed in that flow chart in one place or another, and we will talk about more those tests more coming up. So just a quick review here. You have a gram-positive cocci that is catalase negative, so we know it's a strep. What is the next step in determining additional testing to be done? So we know we've got a strep species. What do we look at next? That hemolytic pattern, because that's going to tell us what testing needs to be performed on the organism. Okay, so now we're going to get more into the different species of streps. The first one that we're going to talk about is strep pyogenes, which are also known as group A strep, which is the causative agent of strep throat. Okay, so strep pyogenes or group A strep, so usually found from, or specimen sources that you could find this isolate from: throats, some wounds, urine, although it's, I think in my 14 or 15 years in the lab, I've only seen it recovered in urine one time, and blood. So diseases that it's associated with: pharyngitis or strep throat. And group A strep is the most common bacterial cause of pharyngitis. Children more commonly will get strep throat than adults. False negatives are possible in the direct antigen tests, and those are the little kit tests that they would perform at the doctor's office. So a culture should always be set up as a backup means of detecting strep throat. Scarlet fever. So this can develop within 1 to 2 days after a group A strep infection, with group A strep species that produce a certain exotoxin called streptococcal pyrogenic exotoxin. It causes a rash that appears on the chest and spreads to the extremities and causes something called strawberry tongue. It's also associated with skin infections, so impetigo, which is a localized skin disease causing weeping lesions. Erysipelas, which is a rare skin infection seen in the elderly. Cellulitis, which is a deeper invasion of the skin, seen a lot of times in patients with vascular disease or diabetes. That can lead to bacteremia, sepsis, or gangrene. Necrotizing fasciitis, which is a skin infection that are prone to progression with involvement of deeper tissue, and organ necrosis, necrosis of the skin. This progresses rapidly. It can be fatal. This is also sometimes referred to as flesh-eating bacteria. And we actually had a student who worked at a hospital a few years ago who had a patient come into the ER. I think her initial diagnosis, she was complaining of her foot or leg hurting. Within 48 hours, this patient had passed. They discovered that she had necrotizing fasciitis, and that quickly she went from being, just a pain in her foot and conscious to being dead. So it progresses very rapidly. Streptococcal toxic shock syndrome, somewhat similar to staphylococcal that we talked about in the first unit. Organs shut down. This can lead to death. The origin of the disease is unknown, though minor injuries or surgeries have been implicated. Young children and elderly are at the greatest risk. Rheumatic fever, this is what's known as a sequelae of group A strep. And so if you look at the word sequelae, you can see the first part of the word spells sequel. So you can think of these this infection as like the sequel to a group A strep infection, where you'll see progressive damage to heart valves that can result. Usually the sequelae, so the difference between scarlet fever, which is not considered a sequelae, and rheumatic fever and acute glomerulonephritis is the time frame. So usually the sequelae, rheumatic fever, could present about a month after infections. This is very rare in the United States though. And then acute glomerulonephritis, also a sequelae of group A strep, where there's an inflammatory response to complexes that deposit in the glomerulus, which is a part of your kidney. So it causes damage to the glomerulus, leads to impairment in kidney function. This one is also more common in children. And then bacteremia, which we mentioned in Unit 1, that's just bacteria in the blood. Okay, group A strep virulence factors, so capsule. It can produce a hyaluronic acid capsule, which prevents phagocytosis. It can mask the antigen, so it remains unrecognized by the host. So antigens are like these little flags or tags on the outside of a cell. That's what our body's immune system recognizes as being something foreign, something that should not be in our body. So if that antigen is masked, then our body is not able to determine that there's a foreign pathogen there and then would not respond appropriately. M protein resists phagocytosis and adheres to mucous membranes. Lipoteichoic acid and protein F, so these are adhesion molecules. They work in conjunction with M proteins to secure attachment of the bacteria to oral mucosal cells. Streptolysin O contributes to tissue invasion and destruction. It causes this is what causes the hemolysis that you will see on your sheep's blood agar or blood agar plate. Streptolysin O is oxygen labile, so again, it doesn't work when it's subjected to oxygen. Active only in an anaerobic environment. Is capable of lysing white cells, platelets, and red cells. Antibodies form in response to streptolysin O. So when our body forms antibodies in response to an antigen, this is referred to as immunogenic. And streptolysin O can be measured in the ASO test. ASO stands for anti-streptolysin O. So this tests for a recent group A strep infection. Okay, it also produces streptolysin S, which is oxygen stable. It's able to lyse white cells. It's non-immunogenic, which means that our immune system would not form antibodies in response to it. Lysis is seen aerobically, around aerobically incubated colonies. Okay, it also produces something called streptokinase, which lyses fibrin clots. The testing for this virulence factor, this enzyme, is not specific for group A because other streps can also form streptokinase. Hyaluronidase, this is another enzyme. It destroys connective tissue, which helps to facilitate the spread of disease. Streptococcal pyogenic exotoxins, aka the scarlet fever toxin. So these are kind of super antigens that are formed by different strains of strep pyogenes. It causes the rash that you see in cases of scarlet fever, and it's associated with symptoms of streptococcal toxic shock syndrome. And then finally, DNase. This is another enzyme. It's got that ACE or ASE ending. Group A produces 4 different DNases, so they're capable of digesting the DNA of the white cells that are supposed to kill the bacteria. Enzymes are antigenic, so antibodies to the DNases can be detected after infection. So remember, our body encounters a foreign antigen, which is kind of like a flag or a tag on the cell surface. And in response to our body coming in contact with that foreign antigen, our immune system forms antibodies. Okay, lab identification for group A strep. Again, the colonies are small, and just generally speaking, the colonies of streps are going to be smaller than those of the staphs. So you've got small, grayish to white, transparent to translucent, beta hemolytic colonies. The hemolysis pattern determines that next step in testing. Remember that. And the beta hemolysis that group A strep produces is much smaller of a zone than that of the staphs. Again, it's catalase negative because it's a strep. It's bacitracin susceptible. So bacitracin is a drug, and again, that drug gets impregnated into little pieces of filter paper, like little discs made of filter paper. Sometimes gets called the A disc. Most other beta hemolytic streps are bacitracin resistant, so this is one way that we can identify group A strep. It's also PYR positive. Most other beta hemolytic strips are PYR negative. This is a disc test also, but it's performed a little bit differently from the bacitracin test. A pink or red color is considered a positive reaction. No color change is negative. Enterococcus is also positive for the PYR test, so you have to be careful. PYR is more specific for group A strep than bacitracin, but if you had an organism that was positive for Enterococcus, you might have to also differentiate and make sure that it's not, differentiate between group A strep and Enterococcus. It is bile esculin negative. It is 6.5% sodium chloride negative, hippurate hydrolysis negative, and CAMP negative. So these other tests down here are tests that we would perform on strep species, but not ones that would identify an organism as positive for group A strep. Treatment for group A strep is penicillin, and really that's true for all of the beta hemolytic streps. They are what's called predictably sensitive to penicillin. So we don't even do sensitivity testing on beta hemolytic streps. It's just kind of a blanket statement that goes out that says this organism is predictably sensitive to penicillin, and that's how the doctors treat it. If the patient is allergic to penicillin, erythromycin is used. Here is a picture of the bacitracin sensitivity test. So you've got these two discs of filter paper that are impregnated with the antibiotic bacitracin. So you have to pick up your suspected colony with your loop, streak it onto the plate, and you do a very thick streak. And on this side, they have done group A strep. On this side, they have done group B strep. So you can see you've got that little tiny zone of inhibition around the A disc. It's sometimes also referred to as a zone of no growth. So that would be considered positive for group A strep. In this one, you can see the organism is growing all the way up to the disc. You do not have that zone of no growth, so it would be negative for bacitracin. Here's a picture of the PYR. Also, this one has to, because we're subculturing the organism and placing that disc there, we have to wait for growth. So this test has to be incubated overnight. We come back and look at the plate the next day, look for those results. Whereas the PYR is, we can perform that within a couple minutes. So we just spread a smear of the organism on the disc. You have to wait a minute and then drop your reagent. And what you're looking for is that pink color to indicate a positive reaction. Okay, the next strep species that we're going to be talking about is group B strep. So sources that we could recover group B strep from: vaginal cultures, blood, wounds, urine. Diseases that it is associated with usually involve neonates and are acquired before or during the birthing process. Because of this, the CDC recommends that all pregnant women be screened for group B strep carriage at 35 to 37 weeks, so that if the mom or the pregnant woman is positive, then they can be given medication to treat so that the baby won't be at risk. This can cause, group B strep can cause spontaneous abortion. So it can colonize the urogenital tract in pregnant women and can pass to the baby during or before delivery. So that's why we screen moms and go ahead and treat them ahead of time before delivery if they're positive. It can cause invasive disease in newborns, late onset. So this usually presents between 1 week and 3 months after delivery. It could present as meningitis, sepsis, and pneumonia. The mortality rate for this one is very high. So again, that's why we screen. Wounds, you'll see group B strep recovered in wounds more commonly in elderly patients with some type of underlying disease or immunodeficiency. And then as it can be recovered from urine as a UTI. Virulence factors, so it can also contain or produce a capsule which prevents phagocytosis. And it says in the book that there are other products produced by group B strep, but that none of them are evidenced to play a role in the virulence of group B strep, so we don't really talk about those. Lab identification, so the colony might be a little bit larger than group A strep colonies, kind of a grayish white, translucent to opaque, very small zone of beta hemolysis. It is CAMP test positive and hipurate hydrolysis positive. So you could perform one or the other. If either one of those tests are positive, then you've identified it as group B strep. It's bacitracin resistant, bile esculin, and 6.5% sodium chloride negative. And again, the treatment for that is penicillin. And that's because it's predictably sensitive to penicillin. So again, that's one of those that we would not do perform sensitivities on. Okay, here's an example of the CAMP test. So the CAMP test is one of those that also we have to subculture and incubate overnight. And what we're doing is streaking, taking a colony of Staph aureus and streaking it straight down the middle of the plate. And then our control organisms are group B and group A strep. Group A is negative, group B is positive. We streak right up to that staph line without touching it. Same for the group B. We have to incubate it overnight, and when we come back the next day, we're looking for this arrowhead of hemolysis is what they call it. So if you've got an organism that produces that arrowhead of hemolysis up against your staph, we can identify that as group B strep. Group A is negative. It's not got that big arrowhead of hemolysis. The hipurate hydrolysis liquid test, but purple is considered a positive result for that one. Okay, the next strep species that we're going to be talking about is Streptococcus pneumoniae. These are alpha hemolytic colonies. So you can see the colony itself is that small inner circle there. That's the organism. That's the actual colony. The larger circle around that is what is that partial hemolysis that has taken place in the media, and it's produced that kind of brownish to greenish color around it. Some of the general characteristics of Streptococcus pneumoniae, so it inhabits the nasopharyngeal areas of healthy individuals, so it's a typical opportunist. So because it can already reside in our bodies as normal flora, it's also got that capability of becoming an opportunistic pathogen. The cell wall contains an antigen referred to as C substance. So this is similar to the C carbohydrate that we use in the Lancefield classification scheme. It can react with a protein called CRP or C-reactive protein in the blood to form a precipitate that increases during inflammation and infection. Some virulence factors produced by strep pneumoniae. Capsular polysaccharide, so it can form a capsule. So strains that have lost the ability to produce the capsule are considered non-pathogenic, but again, capsules just inhibit phagocytosis. And then some toxins that it produces, we've got hemolysis, IgA protease, neuraminidase, hyaluronidase. So none of these have really been shown to have a role in disease production, but they're still considered toxins. Diseases that can be caused by Streptococcus pneumoniae, meningitis. So this usually follows other strep pneumo infections. There's a high mortality rate. There is a vaccine available for elderly and for people without a spleen. Pneumonia, so this results from disruption of the normal barriers. So remember, I just said it can be part of your normal flora. So the most common cause of bacterial pneumonia, which it causes 95% of all bacterial pneumonias, generally not a primary infection. It's usually due to immunosuppression in individuals who have strep pneumo present in their nasopharynx, and their immune systems just are not able to fight it off. Bacteremia often occurs simultaneously with other serious infections. Wound infections, this is not a common organism to recover from wounds. Otitis media, which is an inflammation of the middle ear, most commonly encountered isolate recovered from children 3 years of age or younger that experience recurrent otitis media. Sinusitis, which is an inflammation of the sinus cavity, and then meningitis. Okay, lab identification. It's a gram-positive lancet-shaped diplococci. So lancet-shaped means that it's kind of football-shaped. Diplococci means they come in pairs. Sometimes you can see them in short chains. They're alpha hemolytic. They're encapsulated. Because of that capsule, and this is true not just for Strep pneumoniae, but for other organisms that produce a capsule, they can become extremely mucoid, which is kind of like just kind of like snotty looking on the plate. They're autolytic, which means as they age, the center of the colony will collapse. And again, they can become gram-negative with age. They have complex growth requirements, so blood agar plates and or chocolate for growth. They'll grow on both of those plates. Some strains grow better with increased CO2. You would have to differentiate from strep viridans, and again, that's just mostly because strep pneumoniae, even though it can be an opportunistic pathogen, it can cause more serious infections than strep viridans. Biosolubility test would be positive. Optogen, that's the main one that we're going to use to identify strep pneumo. And that's another, Optogen is an antibiotic. So this is another antibiotic impregnated into a little filter paper disc. And it's performed in the exact same way that the A disc is performed. So we have to streak a plate with a very heavy isolate of our suspected organism and place that disc in the center of that subculture, incubate it overnight, and when we come back the next day, we're looking for that zone of no growth. With the A disc that we use to identify group A strep, any zone of no growth is considered a positive result. For the Optogen test, we have to measure that zone. So it has to be, a positive result is defined as a zone of 16 millimeters or greater. And then finally, the Neufeld-Quellung test would be positive. This is a test for the capsule and can help confirm the identification of strep pneumo. So here's a picture of the Optogen sensitivity test. This one's also referred to as the P disc, and you can see the little P on the disc there, but we've inoculated the plate with colonies of strep pneumo. We've placed that disc in the center of where we streaked, incubated it overnight, and then come back the next day, and you've got that zone of no growth around the disc that we would have to measure. Okay, the viridans group, so just some general information. These are fastidious organisms. Some of them require additional CO2. There are more than 30 species in this group, divided up into 5 groups. So they're hard to speciate. They're not really groupable by the Lancefield classification scheme, but some of the groups in the overall viridans group are strep mitis, strep mutans, strep salivarius, strep equinus, and strep aeruginosus. These are found as normal flora in the upper respiratory tract, female genital tract, and the GI tract. It's considered an opportunistic pathogen, so it can cause bacterial endocarditis in patients with heart valve problems. It can cause abscesses, gingivitis, meningitis, bacteremia. But again, this would, since these species are considered normal flora, this would have to be in an immunocompromised patient to be able to be defined as a pathogen for that patient. Okay, lab identification. Most of these species are going to be alpha hemolytic. They're going to be small colonies. Some of them can be gamma and even more rarely beta hemolytic. They're going to be PYR negative, LAP positive, bioesculin, and sodium chloride negative. So we won't go into that one quite as much. Enterococcus, so here's what it looks, the colonies of Enterococcus look like on the plate. General information about Enterococcus. So it used to be classified as Group D strep, and that's because all species in the Enterococcus group possess the Group D antigen in the Lancefield classification scheme. But in the 1980s, they were divided into the enterococcal and the non-enterococcal groups, with the understanding that organisms found in the intestinal tract were part of that enterococcal group. As more was known about molecular characteristics of each of those subgroups, the enterococcal group was placed into a new genus. Non-enterococcal remained part of Group D strep. So your most common species that you will encounter are Enterococcus faecalis and Enterococcus faecium. Can be found as normal flora in the intestinal tract of humans and animals. Can also be recovered from oropharynx, female genital tract, and the skin. This one is considered an opportunistic pathogen as well. It's frequently a cause of nosocomial infections, with UTI being the main type of nosocomial infection. Can also cause bacteremia, endocarditis, wound or soft tissue infections. Some of the virulence factors produced by Enterococcus. Virulence factors that they produce are becoming an increased concern, and that's because of the organism's increasing ability to cause healthcare acquired infections, and because it's becoming resistant to multiple antibiotics. We won't go into the specific virulence factors that are produced though. So your colony morphology, or again how it looks on the plate, you've got small grayish colonies. Most are non-hemolytic. Very rarely you might find some that are beta hemolysis. This is where it would be especially important to make sure that you're differentiating it from Group A strep, because remember, they are both PYR positive. Group A strep and Enterococcus are both PYR positive, so you would have to make sure to differentiate. Another test that you could use would be the 6.5% sodium chloride and the bile esculin test, for which Enterococcus would be positive for both. When you do these tests, they are done together. So the 6.5% sodium chloride, bile esculin are done together, and it's both of those results, both of those positive results together, that identify an isolate as Enterococcus. It's LAP positive. It might occasionally produce a weak positive catalase reaction, and remember, catalase is what helps us differentiate staph from streps, but that weak positive reaction is going to be nothing like the reaction that you would get from a true staph species. Treatment, so compared to other clinically important gram-positive cocci, Enterococcus is intrinsically more resistant to the antimicrobials used in acute and long-term care settings, including multiple classes of antibiotics. It's resistant to beta-lactams, which are your penicillins, and it's becoming more resistant to vancomycin. If you have an isolate of Enterococcus that is resistant to vancomycin, it is referred to as a VRE, vancomycin resistant Enterococcus. So it's kind of similar in concept to your MRSA. When patients are found to be positive for VRE, isolation precautions are used just like they would be with MRSA. So again, there's the picture of that PYR test. Here's a picture of a positive and negative of your bile esculin and your sodium chloride. So the bile esculin test is a slant agar, so it's just like the agar that's in the petri dishes, but it's poured into a tube. This is what it looks like uninoculated or as a negative result on the left here. The right hand side is a positive result. It turns the media black. And then your sodium chloride is a liquid solution, so it's sodium chloride in water. So on the right, that's your negative result. It's clear. On the left, it's cloudy, which means that the organism was able to grow in that increased salt content, so that would be considered a positive result. Okay, the last little bit of information here. Abiotrophia granulicatella. So these are referred to as streptococcus-like organisms. They were formerly known as nutritionally variant streps. They're part of normal human oral and GI flora. They can be significant causes of bacteremia, endocarditis, and otitis media. It will satellite, colonies of these organisms will satellite with Staph aureus, which means if there is also a colony of Staph aureus on the plate, in conjunction with one of these two organisms, the Abiotrophia or Granulicatella will form like little tiny colonies around the colony of Staph aureus. So that's what it means when we're saying it satellites. These organisms are generally resistant to vancomycin and other antimicrobials. So a lot of times surgery is required to get rid of that infection. Okay, a couple little review slides here. Which disease is considered to be a sequelae of group A strep? And remember, a sequelae, the difference is the time. What denotes it as a sequelae means that it has to occur, about a month after the initial group A strep infection. So acute glomerulonephritis. Rheumatic fever is the other one that is a sequelae of group A strep. And remember, scarlet fever can occur after a group A strep infection, but it's usually within a couple days after. Okay, which group A virulence factor is responsible for anaerobic hemolysis and is immunogenic? And remember, this just means it's able to produce beta hemolysis in an anaerobic environment. Immunogenic means that our immune system would produce antibodies in response to the antigen. So that's streptolysin O. Pregnant women are tested as carriers for which organism, which can be deadly to infants? That's your group B strep. Which organism is the cause of about 95% of all cases of bacterial pneumonia? That would be your strep pneumoniae. And then lastly, so you've got a tech who sets up a bile esculin and sodium chloride. The next day, the bile esculin is black, which is a positive reaction, and the sodium chloride is clear, which is a negative reaction. The organism is group D or viridans. And I'm sorry, we didn't, I don't know if we went through that explicitly in the notes, but that is why both of those have to be performed together, the bile esculin and sodium chloride, because that's how you differentiate Enterococcus from group D or viridans. Enterococcus would be positive for both of those tests. Group D and viridans would be positive for the bile esculin, but negative for the sodium chloride. So that's the end of the first section of notes for Unit 2.